Thank you, Chairpersons. Good afternoon. It's an honor to be here to share our perspectives on congenital nasolacrimal duct obstructions. Those of us who do general ophthalmology, pediatric ophthalmology, we know tearing is a major problem, not just in adults. Compliments to Dr. Alambri and the entire team for putting this meeting together. So this is the group of patients that we're going to be talking about for the next 10 minutes or so. These young kids with wet, sticky eyes, where we just tell the mother, put some antibiotic eye drops, do some massages, compressions, and come back 1 year later. Are we really doing them a favor? The answer is no, because you don't wait for a year while a child is suffering with wet, sticky eyes and swollen eyes itself. But it's important to keep in mind that just because a child is tearing, it is not just NLD obstruction. There are a lot of other reasons why kids would tear. And that's why we become complete ophthalmologists to do a complete examination, make sure we rule out secondary causes of tearing before we label it as a congenital NLD obstructions. And we are all taught about the lower end membranous non-opening of the nasolacrimal duct. Remember, there are a lot of other locations where NLD obstructions can happen. So this is a diagrammatic representation from Dr. Jane Olver's group, the current president of ISDDE, which talks about the passage where the NLD opens in the inferior orifice below the inferior turbinate. And that's a typical location where we think, where we do our routine probing, we're able to get away with it with 90-95% success. But you don't realize that every child is different, and you can have various other atypical locations of obstructions, or even kids who have multiple level obstructions, including complete atresia. Big studies where the Japanese population have shown that even the angulation of the nasolacrimal duct is very different. Hence, blindly passing a straight probe down the nasolacrimal duct, blindly, and blind is a bad word in ophthalmology, is the reason why sometimes we have disasters and failures. We think we've done a great job, the child is still symptomatic, and we have lots of failures, and we don't know what's really going on as well. Also keep in mind that in countries which have a high birth rate, there are a lot of syndromic anomalies. And the nasolacrimal duct that is formed, for example, if you see in the CT scan, it's an axial cut where you're showing actually the nasolacrimal duct is horizontal, not the vertical passage of posterior lateral that we're all taught about in textbook anatomy. And the angulation of children is very different from the angulation that we see in kids. Hence, using adult anatomy to translate it into pediatric probing is also the reason why we have sometimes complications and failures. Keep in mind that there are these syndromic kids. Keep in mind that there are standard children who have varied anatomical pathways itself. And yes, we taught about lacrimal sac compressions. So I'm going to show you how we manage typical NLD obstructions in patients who have present with tearing and discharge at month 1, month 2, month 3, month 4, month 5. And that's a sequence of pathway that we really manage. And in the past, we could get away with these things, simple nasal speculum, Bowman probes, syringing cannula. But now you realize that pediatric obstructions is completely different. Without doing nasal endoscopy and doing a blind probing is no longer adequate for these patients. So let me play this video, which is in the American Academy of Ophthalmology website. If that video plays, can you click on the video, please? And there's an audio to it that goes along with it as well. Audio doesn't play. Anyway, I'll talk through it because audio is gone completely. You can see that a lot of them spontaneously reopen, and that's the reason why we used to sit and wait.
This is a video presentation of the spectrum among variations in pathology. The most common cause is the duct that fails to open through the nasal muscles.
And increase the volume.
How do we approach this condition?
So you're going to go step by step, lacrimal sac compressions. It's not lacrimal sac massages, it's lacrimal sac compressions.
This approach does not resolve the tearing. The next step in management includes lacrimal irrigation and probing to rupture the presumptive membrane occluding the duct.
And direct confirmation using a nasal endoscope is important, not just doing a metal on metal contact.
Address tearing. Next step in management involves bicanalicular intubation.
Rather than monocanalical intubation, and they have this advantages. We'll talk about it later. Once again, instead of blindly retrieving the probes, and a direct visualization is important. Tie it down with a tipple square knot, and the advantage of a simple square knot is you can retrieve it in the office post-operatively.
An obstruction appears lying in firm. Balloon dacryoplasty could be performed to rupture and widen the distal duct opening.
This, unfortunately, post-COVID, there's a difficulty securing balloon dacryoplasty in patients. However, there are new companies which are now coming up with it. So this is an alternative to bicanalical intubation in patients with late presentations and atypical obstructions. Of course, you can confirm patency by aspirating fluorescein stained liquid through the nose and through the suction aspirate.
Finally, as a last resort when all else fails, an endoscopic DCR could be performed as a multidisciplinary approach together with an immunologist.
So in the past, we are notorious for doing external DCR for children. That's a completely history now. You don't want to be making external incisions. In fact, endoscopic DCR in children is much easier than you would do for adults. It's a simple abscess drainage through the nasal cavity, which does not involve any kind of destruction of extensive bone or causing a scar itself. So this is what we have learned during our residency and reading from textbooks. And this is the kind of outcomes that you would see when you have successfully managed these patients. But however, when you do enough of it, not infrequently, you do see failed probing. Dacroendoscopy is coming in a big way. These are 0.9 millimeter microendoscopes which are now passing down the nasolacrimal duct. The oldest patient I've been referred with a congenital NLD obstruction is a 24-year-old lady who was pregnant. Believe it or not, with tearing and discharge, such a nuisance that I had to do a probing and recanalization for her. And of course, dealing with pediatric dacrocystitis. And we think about failed probing and said, oh, it's the child's anatomy. It's not the child's anatomy completely. It's us as well, blindly doing the things as well. We know the failure rate is higher when the older the child is, when you have dense multiple level obstructions and false passages as well. And there are different factors that come in the predisposing towards NLD obstructions. And that's where not probing in the office, but probing in the general anesthesia is very important. By a dedicated pediatric and lacrimal trained oculoplastic surgeon is very important. Using nasal endoscopic guidance is important. And when there's a high risk of failure, doing routine bicanalicular intubation is important. So what's really new in dacryology? This is actually a news from last week where they stuck a 6 millimeter endoscope through a hole in a pyramid to understand the caverns within the Giza pyramids. Likewise, we now have these angulated 0.9 millimeter microendoscopes which can pass through the punctum and canalicus and nasolacrimal duct. They come into different bends where we are first time we are now able to visualize what is really happening inside. Just as how I think visualization in the nasal cavity is very important for any rhinological procedures, we now need to understand what's really going on. These are the typical images you see at various locations at parts of the nasolacrimal duct. And you can diagnose various pathologies in patients from membrane and in adults with foreign bodies, so on and so forth. So this is an example of patient where we are now starting off with a nasal endoscopy. This is a child with tearing on the right side. Anas, who was here in the crowd, he was there when we did this case last year, where we confirmed that there's no flow of fluorescein on the right side, confirmed that the normal turbinates, there's no mucocele, and on the left side you can see fluorescein. So it correlates with what we see. And then under general anesthesia, we are now able to pass this microendoscope, identifying the various structures, and this is through the canalicus. We prefer to go through the upper canalicus into the lacrimal sac. You can now see the lumen. Of course, the visualization, the resolution is also important as you go along as well. You need a good assistant to keep flushing and insufflating the nasolacrimal duct. You can see pus inside which you need to flush out. And once you're in the lacrimal sac, we now seek out the nasolacrimal duct, which is seen as a beautiful lumen right now inside. You can see dilated mucosal folds in patients with chronic obstructions. And we are able to go down the nasolacrimal duct, not just blindly passing a nasal probe into the nasal cavity, thinking that you have done a recanalization of a membranous obstruction. Even the metal on metal contact that we do blindly, you can have a buried probe and you think you'll get a success rate, you won't be there. And finally, you're now able to get into the nasolacrimal duct. So when you have late presentations, when you have failures, in the past, yes, we were doing a lot of DCRs. Nowadays, we do ELDRs, endoluminal lacrimal duct recanalization, with or without an endoscopy. And these are patients now, even in much older children where we were doing DCRs, we were able to recanalize these systems. And finally, of course, when all else fails, the anatomical differences are quite multiple at various levels. The child has had late presentations with multiple level scarring, and you do have a dacryocystitis, a chronic recurrent dacryocystitis, then don't hesitate to do a DCR. You can always attempt a probing with ELDR first, and if that fails, do a DCR, but not an external DCR, but an endoscopic DCR. So these are all examples of children where we have done an endoscopic DCR, which is much faster, simpler compared to adults, so they can develop good obstructions. So in summary, I think coming to the end of it, number one, yes, when you have typical lower end NLD obstruction, which we don't know ahead of time until you do the office probing or the operating theater probing, yes, you can do a simple probing, typical less than 1 year of age. That's all you need to do, not need to do intubation. However, if you have a complex child with complex pathology, much older children, and you're doing the probing atraumatically, multiple level obstruction, or fail probing elsewhere, you go on to the adjuvants, including intubation. Infracture inferior turbinate does not increase the success rate, but helps you visualize what's going on underneath and do a balloon dacryoplasty. But when you see atypical cases, syndromic cases, or repeat procedures, do not blindly but dacryendoscopy guided. And of course, when you have recurrent dacryocystitis, do a DCR, but an endoscopic DCR. So with that, I'd like to thank the chairpersons for giving me the time to share recent advances in congenital NLD obstructions. Those of you interested in ocular surfaces diseases and dry eyes, I welcome you to our next meeting. We're going to be doing in Estonia and Europe in June next year. We did the 13th meeting in Singapore. Thank you very much.
Thank you. Thank you very much, Ganga. Can you tell us the dates, the age of the patient regarding each procedure? But I think it matters, right? What's the cut-off of probing and syringing, and then intubation, and then proceeding with other procedures, as you mentioned?
Absolutely. I think the age is very important. In the past, we were told wait till 15 months of age. No, I don't wait anymore, actually. In fact, the moment a child is symptomatic and you teach a mother lacrimal sac compressions, what does a mother do? Give it to the grandmother. The grandmother in turn gives it to the domestic helper, who do a terrible job. So it's supervised, and if they do a good job, 1 month, 2 months, and the child is symptomatic, I don't even wait for a year to do the probing, number one. Number two, when the child presents at 12 to 15 months and you pass down the probe or endoscopy guided, it's a typical lower end obstruction. Probing alone is sufficient. But as a much older child and you're probing down, further down, that's when I go to intubation. See, in the past, I was doing a lot of intubation for these kids, but when I had the balloon dacryoplasty and we had children coming from far away who could not come back from tube removal, balloon dacryoplasty was a replacement.
Okay.
But the older the child, you're right, the higher risk of failure, so you would do a lacrimal intubation for these kids.
Okay, and you leave the tube for 6 months?
No, actually 6 weeks to 3 months at the most. A lot of times these kids rub their eyes and pull the tubes out themselves, and lo and behold, they still are asymptomatic. So I still am not convinced whether the tube is doing the good job. I think what the tube does is makes sure that the child comes back for follow-up for you to see what really is going on.
Okay. You mentioned about the endoscope. Is this like laser mounted? Do you have a cutting laser with it? Because it would be much easier to go and dissect synechia or open a Hustler valve or anything like that.
Right. I have a separate talk purely on dacryendoscopy and ELDRs. It has 3 different channels, one for irrigation, one for instrumentation, and all this stuff. But a lot of times what you're doing is recanalization is just pure mechanical. I think people have more or less abandoned lasers nowadays for lacrimal procedures because it causes a lot of scarring and fibrosis as well. So it's all more mechanical recanalization with intubation that we now do, actually.
Can you take biopsy?
You use a sheath. There's a nice 19 gauge sheath through which you can pass the endoscope, and the sheath is what recanalizes while you're passing the endoscope from behind, and you can directly see it before you do the intubation.
Can you take a biopsy through the channels using special instruments?
I don't have the technology yet. So I guess theoretically with micro robotics now, I think it's going to be happening in the future, not at this point of time.
The micro robotics. Thank you.
And nanotechnology, all of that is going to change how we're going to be managing. But up until this time, direct visualization through the nose, and that alone is not sufficient. Direct visualization through the lumen of the nasolacrimal is probably the way to go. Thank you very much.
Thank you, Dr. Ganga. I have a question for you. What percentage of your patients undergoes balloon dacryoplasty in your practice?
So what's happening again with the supply chain affected through COVID, we are having a lot of difficulty. So we've only still using the old stocks that we used to have, and I have difficulties now with American companies, European companies. The no financial conflicts of interest. FCI now makes these balloon catheters, but they're only 2 to 3 millimeters in diameter. And I don't think that quite does it. Whereas in the past, Atrian Ophthalmomedics had a 5 millimeter balloon catheter for older children, which was quite effective. So I've stopped doing the 2-3 millimeters for young children. I still have the 5 millimeters, what I end up using actually. Yeah.
Thank you so much.
Fine. Thank you.
Thank you very
Thank
much.
you, Dr. Sundar.